Welcome to Mastering the Gut, Bridging the Lab Gap. This module covers CBC morphologic analysis and how altered structure causes altered function of the red blood cells. Anemia is functionally defined as an insufficient red blood cell mass to adequately deliver oxygen to peripheral tissue. However, this assumes the cells are of normal size and shape. This also assumes if there is a problem, it can involve only one of the specific diagnosable anemias. Impaired red blood cell deformability, which occurs with inflammation, shifting pH, and altered blood chemistry, contribute to the development of multiple organ dysfunction syndromes by impairing tissue microvascular blood flow. This places extra demand on bone marrow producing the blood cells. Chronic inflammation or constant immune stimulation through supplements and bone broth accelerates bone marrow dysfunction, leading to myelodysplastic condition such as myelocytic anemia. As a result of these multiple factors influencing the formation of blood cells, it is far more likely that patients can have multiple blood cell types. This makes analysis of CBC results confusing because they do not fit into a specific type of anemia. Anisocytosis is a medical term meaning that a patient's red blood cells are of unequal size. This is commonly found in anemia and other blood conditions. False diagnostic flagging may be triggered by an elevated white blood cell count, agglutinated red blood cells, red blood cell fragments, giant platelets, or platelet clumps. Elevated RDW is a measurement of anocytosis. Anocytosis is identified by RDW and is classified according to the size of the red blood cells measured by MCV. Examples of anisocytosis with more small cells known as microcytes are iron anemia, anemia of chronic inflammation, and anemia of chronic disease. On the other side of the scale, anisocytosis with macrocytes or large cells becoming more predominant are folate or vitamin B12 deficiency, autoimmune hemolytic anemia, cytotoxic chemotherapy, chronic liver dysfunction, and myelodysplastic syndromes. Other possibilities with anisocytosis is dimorphic anemia and pancytopenia. In dimorphic anemia, the patient may have multiple red blood cell populations. The dimorphic blood picture will look like a population of small, normal, and large cells of different sizes and forms. The blood picture shows the presence of morphologically different red blood cells. The cause of the dimorphic anemia has to be established in order to systematically manage the patient. Combined deficiencies of iron due to anemia of chronic inflammation or chronic disease and folic acid more commonly lead to dimorphic anemia with clinical features of both forms of anemia. Pancytopenia is an important clinical entity encountered in our day-to-day clinical practice. There are varying trends in its clinical pattern, treatment modalities, and outcome. It is a disorder in which all three forms of the blood elements, red blood cells, white blood cells, and platelets, are decreased in number. It is not a disease entity, but a triad of findings that may result from a number of disease processes, primarily or secondarily involving the bone marrow. Patients report generalized weakness, breathing problems, chills, intermittent fevers or hot flashes. Patients with pancytopenia will have physical complaints that include sciatica without evidence of a disc bulge, or hip or acetabular pain. Usually only normal, mature, or nearly mature cells are released into the bloodstream. but certain circumstances can induce the bone marrow to release immature and/or abnormal cells into the circulation. A dacrocyte or dacryocyte is a type of poikilocyte that is shaped like a teardrop. A marked increase in dacrocytes is known as dacrocytosis. These teardrop cells are found also in beta thalassemia major, especially after splenectomy. Dacrocytosis can be associated with myelofibrosis anemia, commonly caused by myelofibrosis. This is associated with bone marrow infiltration. Myelofibrosis can occur after damage to the bone marrow stem cells, resulting in fibrosis. This leads to replacement of the bone marrow with collagenous connective tissue. These teardrop shapes is the result of the red blood cell being forced out of the bone marrow with a protein attached to it. The dacrocyte is appropriately recognized as the hallmark poikilocyte of leukoerythroblastosis. Leukoerythroblastic anemia was defined by Vaughan in 1936 as an anemia characterized by the presence in the peripheral blood of immature red cells and a few immature white cells of the myeloid series. Myelofibrosis is a form of bone marrow failure due to replacement of hemopoietic tissue by abnormal tissue. This often mimics sciatic pain. This results in extramedullary hemopoiesis, typically in the spleen, leading to premature release of hemopoietic cells into circulation. Peripheral blood findings may include nucleated red blood cells, teardrop forms, giant platelets, and immature leukocytes. The result of this bone marrow inflammation and bone marrow fatigue is extensive scarring in the bone marrow, leading to severe anemia, weakness, fatigue, and often an enlarged spleen or liver. The finding of the dacrocytes in the peripheral blood smear or live cell analysis can be an indication of bone marrow fatigue when associated with reduced red and white blood cell counts. As acids accumulate in the body, they get stored and pushed into the tissues. The area they get pushed to, on a local level, is going to be, in a large measure, where the body or with what organ is experiencing problems. When the body stores a molecule of excess acid, it will compensate by placing an extra alkaline atom or molecule in the blood. The blood will therefore become increasingly alkaline. Colloids are held in suspension via a very slight negative electrical charge on the surface of each particle. Like charges repel each other. This charge is called the zeta potential. Blood is a colloidal solution, and all blood cells have a slight negative charge. Zeta potential is a measure of the electrical force that exists between the atoms, molecules, and particles in cells in the fluid. Zeta potential strength determines the amount of material, either nutrients or waste, that the fluids such as your blood and lymph can carry. Increasing the electrical force of the solution allows the fluid to dissolve and hold more material. In this way, more nutrients can be carried throughout the body, and accumulated deposits of waste can be removed. When the zeta potential is too low, blood begins to coagulate or agglutinate. This is a condition known as red blood cell aggregation. Blood becomes a sludge that is increasingly difficult for the heart to pump and is decreasingly effective at performing the usual functions of blood. Blood is in constant motion at a constant temperature, and the pH of the blood is fixed at 7.35 to 7.4. But its concentration of electrolytes is not fixed, and the electrolytes directly affect the zeta potential. Now, something interesting happens with the uptake of oxygen when the blood is overly alkaline. With rising alkalinity, blood can increase its oxygen uptake. Therefore, the blood cells can hold more oxygen. Well, that's a good thing, don't you think? The blood can hold more oxygen? Well, if you think that, you're wrong. The reason is a little bit of biochemical reality known as the Bohr effect. The Bohr effect states that with rising blood alkalinity, the red blood cells can saturate themselves with even more oxygen. The problem is they can't let go of it. And if the blood cells can't let go of oxygen, then the oxygen isn't getting down to the other cells of the body. And do you recall that cancer grows in an oxygen-deficient environment? Now let's go further. We have alkaline blood due to the fact that we have increasingly acidic tissue and/or cells occurring somewhere in the body. We have alkaline blood which can't let go of its oxygen to aerate an increasingly acidic environment. This state that was just described is brought to fruition through dietary and environmental factors combined with microbial productions of acid and gases to which the body is being subjected to. No part of the body can be understood separate from the whole. Alkaline food fermented by bacteria will turn acidic. This state where we have an excess acid load in the tissues, where the blood shifts alkaline, where the Bohr effect comes into play, where plenty of oxygen is in the blood but is not getting to the tissues, this state is one of anaerobic metabolism and could be termed an anaerobic or overly anabolic condition. The interplay of the key minerals, calcium, potassium, sodium, and magnesium, when their ratios are affected, can drive the vasomotor system to be stuck in either sympathetic or parasympathetic mode. Now, just as there is one type of condition, there is always the opposite on the teeter-totter of life. We can see a completely different scenario of what was just described. The opposite state here would see blood shifting to the acid side, the tissues going alkaline. The Bohr effect coming into play more at the tissue side of things, whereby oxygen uptake increases, which sounds like a good thing. But oxygen is also an oxidizer. And to an extreme, too much means oxygen utilization is out of control. This leads to a dysaerobic or overly catabolic state. In one state, overly anabolic, we are ripe for cancer. In the other, overly catabolic, we are ripe for heart disease or premature aging. How can we win? And to make matters worse, if you thought the autonomic nervous system only gets stuck on the sympathetic side, where we are overly stressed, rant, rave, and burn out, and have adrenal fatigue, the ratios and balances of these four primary minerals can shift, and we can get stuck and locked into a parasympathetic dominance, where a person is perpetually fatigued, foggy thinkers, prone to allergies and asthma. This is the state of chronic illness and autoimmune conditions. Red blood cells aggregate face to face to form long, cylindrical, straight chains and sometimes branched structures called rouleaux. When rouleaux grow large, they may contain rings or loops or take on the appearance of a network. In a vessel wider than the major diameter of a red blood cell, the branching of rouleaux is prominent and is an important determinant of the kinetic behavior of the red blood cells. The red cells stick together due to undigested proteins that have gotten into the blood, shifting the isoelectric point. These proteins have not completely digested, leaving an imbalanced isoelectric point. A normal feature of the electrostatic charges is that the negative should repel negative, positive should repel positive. The surface of the red blood cells have a slight negative charge. Because the pH of the blood is slightly outside of the ideal isoelectric point, reducing the zeta potential between the red blood cells, their normal electrostatic charges that would repel them now attract them. This is increased when one or more of the cells are damaged. These red cells are stuck together, which means that there is a series of consequences ranging from a shift in the pH and zeta potential, free radical damage, microbial endotoxins, and altered hemopoiesis. The electrostatic charges bringing them together, and that the proteins are very sticky, make them difficult to break apart. When the red cells are like this, they do not fit through the capillaries. This results in fatigue, brain fog, muscle weakness, to name a few of the symptoms, due to the pancreas exocrine insufficiency and the consequential poor digestion, incomplete bowel movements, all associated with this clumping of the red blood cells. Areas of high turbulence in the vasculature accelerate the release of oxygen from hemoglobin. This occurs in the heart, bifurcations or junctions of the arterioles. Release of oxygen and ATP results in agglutination and Rouleaux formation, further depriving tissues of needed oxygen and energy. Erythrocytes release ATP in response to the combined effects of hypoxia and hypercapnia. Red blood cell exposure to reduced oxygen tension alone is sufficient to stimulate ATP release from the erythrocytes. The release of ATP from red blood cells occurs in response to small changes in pH and zeta potential, oxygen concentrations, or osmotic pressure. Physiologically, erythrocytes release ATP in response to mechanical deformation, as would be encountered when the cells traverse the microcirculation or alterations in their structure. A variety of diseases are linked to impaired ATP release from red blood cells, including cystic fibrosis, pulmonary hypotension, insulin resistance, and diabetes. Echinocytosis of erythrocytes by glucose depletion is attributed to ATP depletion. Formation of echinocytes includes exposure to anionic amphipaths, high salt, high pH, ATP depletion, elevated cholesterol, LDL, and HDL. This induces a series of crenated shapes called echinocytes, characterized by convex, rounded protrusions or spicules. Elevated cholesterol and HDL induces erythrocyte transformation into echinocytes. Exposure of erythrocytes to elevations of plasma LDL induces the erythrocytes to undergo morphologic transition from biconcave disc to echinocytes and spherocytes. Patients with liver dysfunction produce echinocytes rapidly with elevated HDL. Under further exposure, the spicules become smaller and more numerous and eventually bud off irreversibly, forming extracellular vesicles composed of plasma membrane material and leaving behind a more or less spherical body with reduced area and volume known as spheroechinocyte. A similar but opposite set of agents, including cationic amphipaths, low salt, low pH, cholesterol depletion, induces a concave shape erythrocyte called a stomatocyte. Acanthocytes have only a few spicules of varying size that project from the cell surface at irregular intervals. The shape of these cells is thought to be related to changes in the organization of the cell membrane components. In acanthocytes, this is often due to a defect in the lipid or protein composition of the red blood cell membrane. The presence of chorea or neuropsychiatric disturbances associated with elevated creatine kinase levels, epilepsy, and hyporeflexia suggests the presence of acanthocytes. Lectins are mild natural toxins that are not limited to just grains, but are found in especially high levels in most common fruits that are harvested while still immature for travel over long distances to market. While ensuring survivability until arriving at the distribution centers and then gas ripened prior to sale, the lectins are still active when health-conscious consumers eat them. Lectins, by design, are meant to irritate the gastrointestinal tract of animals and birds. This is nature's distribution method to move the seeds away from the parent plant. By irritating the gastrointestinal lining, the seeds speed their way through the gut before being digested. These natural toxins are meant to protect the seed on the parent plant until maturity, or to survive winter on the ground until the next growing season, occur not only in organic and conventional produce, but are being hybridized and genetically modified, accentuating their potency. Lectins are known to unlock or break through the barrier variables of the gastrointestinal lining and allow large, undigested protein molecules into the bloodstream. Lectins bind to erythrocytes simultaneously with immune factors that cause hemagglutination, anemia, and immune activation. This immune activation is invisible to immunoglobulin testing. The immune response occurs through the histamine and complement cascade, and only through a PHA-stimulated cytokine panel can the immune response to lectins be quantified. Lectin researchers have found that panhemagglutinin lectins inhibit the natural repair system of the gastrointestinal tract by potentially leaving the rest of the body open to the impact of errant, wandering, unwanted material from the digestive system. This is especially true when the lectins unlock the barriers to entry and allow the larger undigested protein molecules into the bloodstream. Panhemagglutinin lectins can bind to red blood cells, causing the cells to clump together, resulting in a form of anemia. Lectins in the bloodstream have been shown to cause a significant increase in hemoglobin, hematocrit, red blood cells, MCV, MCHC, and MCH, as well as increased neutrophil levels. The platelet count can be significantly reduced while remaining within the normal levels. This breach can initiate all kinds of immune-related havoc and is thought to be related to the development of autoimmune disorders. In red blood cell agglutination, two erythrocytes adhering to one another are counted as one with automated counters. Larger clumps are not counted as red blood cells at all. This leads to a decrease in the red blood cell count and falsely elevated MCV. The degree of red cell agglutination induced by high molecular mass polymers is dependent on hematocrit. There is a much shorter time required for red blood cell aggregation to begin and reach completion with higher levels of hematocrit. The age of the red blood cells is involved in aggregation. Relatively young red blood cells have approximately 3 times lower the agglutination ability when compared with older cells. Autoagglutination activity is known to be a marker of virulence in gram-negative bacterial pathogens, including Mycoplasma, Vibrio, Bordetella, Neisseria, Yersinia, and Aromonas species. Pillins, or outer membrane proteins of these bacteria, have been demonstrated to be autoagglutinins. Autoagglutination is seen to occur in a type of immune-mediated hemolytic anemia known as cold antibody hemolytic anemia. Automated cell counters may produce abnormal values, as the agglutinated cells may be counted as single cells. Problems can also occur when the autoagglutinated blood is tested for ABO and Rh blood groupings and typings, and during cross-matching at the blood bank. The agglutination results in the blood being typed uniformly as AB positive and as being incompatible at cross-match. Diagnosis of autoagglutination can be confirmed by a positive direct antiglobulin test, aka the direct Coombs test, using Coombs serum. The development of cold agglutinins, as cold-reacting antibodies are also known as, may result from the following conditions: infection from mycoplasma organisms, infectious mononucleosis, lymphoid malignant disorders, and other unknown causes. The first stage of microbial infection is colonization. Survival of the microbe requires the establishment of their preferred niche and modus operandi. Pathogens usually colonize host tissues that are in direct contact with the external environment. Some microbes, such as mycoplasma, actively seek out areas of high oxygen and ATP concentrations. Mycoplasmas possess very limited metabolic and biosynthetic activities for proteins, carbohydrates, and lipids in comparison to conventional bacteria. Like other molecules, it scavenges for nucleic acid precursors and ATP. Attachment to the red blood cells is the ideal niche environment for mycobacteria. Red blood cells release massive amounts of ATP and oxygen when they lose their deformability and during agglutination. There is also plentiful supply for them to colonize. Mycoplasmas adhere to human erythrocytes, and electron microscopy shows that mycoplasmas do not merely adhere to the erythrocytes, but deforms them by producing depressions in the red blood cell surface in which the mycoplasmas adhere closely. These unculturable mycoplasmas parasitize erythrocytes and produce acute and chronic blood infections with hemolytic anemia and other illnesses. Mycoplasmas produce erythrocyte cold agglutinins in half or more of patients. Signs and symptoms of cold agglutination syndrome include changes in the skin on the nose, ears, lips, hands, and feet in response to cold, also known as Raynaud's phenomenon, painful fingers and toes with cold exposure, and even death of the tissue due to insufficient blood supply or ischemic necrosis. These symptoms can occur at room temperature as seen in these images. There are no free-living mycoplasmas. They are strictly parasitic and cause chronic but mild infections. Mycoplasma infections can also immortalize immune cells. A common complaint of mycoplasma infection is painful fingers and toes with purplish discoloration associated when exposed to cold. This can even be room temperature. In chronic cold agglutinin disease, the patient is more symptomatic during the colder months associated with Raynaud's or cold agglutinin signs and symptoms. In most people, mycoplasma persist as a latent infection in which the mycoplasma is contained but not eradicated by the immune response. Interferon gamma, an intact CD4 T cell response, IL-12, and TNF-alpha are required for control of mycobacterial infections. Mycoplasma overcome macrophage bactericidal activity and persist intercellularly. Live bacteria are not necessary for macrophage inhibition, as gamma-irradiated mycoplasma also inhibit interferon gamma responses in macrophages. Mycoplasma cell wall components, including the lipoproteins and peptidoglycans of the cell wall core, inhibit macrophage responses to interferon gamma. When natural killer cells become activated in response to mycoplasma, they release their cytoplasmic granules, which contain granulysin and other mediators, to directly kill the host cells and/or bacteria. However, natural killer cell-derived granules are not able to directly kill mycoplasmas, and mycoplasmas do not interfere with granule activity. In addition to this, natural killer cell granules cause bystander damage and kill macrophages and damage tissues, especially in interferon gamma deficient environments of those that are immune compromised, which could lead to further impairment of innate immunity. Opportunistic and pathogenic bacteria that penetrate past the epithelial barrier, entering the bloodstream, are efficiently killed by macrophages. It is clear that the immune system is not ignorant of their presence of bacteria, because a vigorous IgA response directed against these microbes can be measured, and a significant proportion of this IgA is induced through a T-cell independent pathway. This high-speed video shows a macrophage chasing down planktonic bacteria. This is likely a segmented filamentous bacterium, as it appears to be attempting to escape capture. Eventually, the macrophage is able to phagocytize the bacterium. An optimally functioning immune system is required for such events to occur in the body. In the next video, we observe a different scenario. In this second video, you can see a red blood cell infected by mycoplasma with the characteristic bumps. Two macrophages are attracted to the infected cell. As one macrophage is aggressively moving towards the cell, it is joined by another macrophage. The second macrophage is immediately repulsed from the mycoplasma-infected red blood cell. The first macrophage makes another attempt from a different direction. Eventually, both macrophages move quickly away from the mycoplasma-infected red blood cell. Molecular mimicry of host molecules enables bacteria to display surface molecules resembling those of the host. This contributes to immune hyporesponsiveness to bacteria. Recent analysis has revealed the presence of secretion systems in commensal bacteria. Previously, such secretion systems have only been described for pathogenic bacteria. Opportunistic bacteria also use analogous secretion systems to deliver effector molecules that subsequently mediate their evasion of immune surveillance mechanisms in the body. This typifies the interaction between microbes and immune cells at the cellular level in immune-compromised individuals, where immune cells are rendered incapable of protecting the body. This concludes Unit 2 of Bridging the Lab Gap, CBC Morphology. Thank you for watching the Mastering the Gut. Altered structure causes altered function. You may take the quiz and then proceed to the next module.